Our lecture today is about adult orthodontics. So, what do we mean by adult orthodontics? It's a provision of orthodontic treatment for adult patients who usually has stopped growing. So, we are treating patients, usually we have adolescent and we have adult patients who finished the growth, and we're going to see later why these adult patients are different from adolescent patient. Now, in the recent years, there has been an increased demand on adults seeking orthodontic treatment, and that could be because of the increase of the awareness of the aesthetic improvement that the patient can achieve with orthodontic treatment, and then it becomes now more socially acceptable for the adult patients to have braces. So more and more you see adult patients with braces, and these two factors have been increased by the effect of the media, particularly the social media. So the people become, or adults patients become more aware of their teeth, and it become more acceptable to have braces. And that's come with the expansion and the huge development of the aesthetic appliances like clear aligners and clear braces like ceramic brackets. And also, patients might be not happy with the previous orthodontic treatment, so that's kind of all causes why there's increase in the demand. Now, in the UK, usually, if you, in the surveys check the adult patients who seek orthodontic treatment, the majority of them are younger than 40 years old. However, the majority of them are females. So mostly females seek orthodontic treatments more than males in the adults. And there is a significant people who has a tooth loss, which means either a material loss of the tooth due to attrition or even to loss of the whole tooth of extractions. It's very important when you have adult patient, to check what is the motivation of the patient to seek orthodontic treatment, why he's here. Sometimes it's aesthetic, and sometimes it's because TMD and TMJ function may be referred for perio/prosto reason. Maybe patient's going to go for orthognathic surgery, and part of his orthognathic surgery treatment, you might benefit from orthodontic treatment as a pre-surgical orthodontics. Some of them are coming for to correct sleep apnea. In a study done by Cedro et al. In 2010, he found that 80 or like 70% of the chief complaint of the adult patients, was to straighten the teeth. However, more than 60 by a little bit, they complain that they need to improve the smile. Some of them reduce the spaces, and all these the list of the complaint that adult patients came with. It's very important, however, when you have an adult patient, to ask him these questions. Why? You need to be very specific about what is the concern of the patient, because usually adult patients, they know what they want, not like an adolescent patient. And sometimes adolescent patients, they just need the teeth straightened, but adult patient, they have a specific complaint. So they might say, for example, we don't like the shape or the color of the teeth. Well, then if that's happened, and they don't like the color of the shade, that means they can go for orthodontic treatment, because the treatment here is veneers, or orthodontic treatment then followed by veneers. The other question is, why now? Why did you decide to go for EA? For example, if you get patients who's 40 and he's been happy all these years with his teeth, what made him change his mind and he decided to go for orthodontic treatment? And what is important the most is the expectation of the treatment. Usually adult patients have a higher expectation compared to the adolescent. So you need to know exactly what is your adult patient expected after the treatment. And also you need to know if there is any anxiety toward treatment, because usually this anxiety comes from the aesthetic of the appliances, and if they're going to have sore mouth of these appliances. So you need to know exactly what makes them anxious. That's an example of adult patient. She seeks the treatment just simply to improve the appearance of the front teeth, and that's what is done. Now, we're going to start with this lecture, and as a whole lecture we discuss why and what are the aspects that we need to consider in a different way when we are treating adult orthodontic compared to adolescent orthodontics. So we'll start first with the medical history of the patient. Now, usually when you have adult patient, they're more likely to have medical problems compared to the adolescent patient. So we always have to check the medical history, but when we have an adult patient, we might it's more common to find medical problems. Psychology, and this is very important. Kids are usually simpler than adults. Usually, when they attend the clinic, they have teasing and bullying in school, so they need to get rid of that. They get the braces done. But adults are slightly more complicated. Like 50% of the adult patient have unstable or neurotic personality. So which means that dealing with them could be very tricky. Usually adult patient has a higher expectation of the treatment. So basically the adult patient, they, for example, spare time from work to come to the clinic, they pay money from their salary, they know why they are spending the money, so they will be like having more and higher expectation compared to the adult. And the most important one is the true motivation for treatment. And that's very important now. And we mentioned and discussed that in the orthodontic surgery. If a patient comes to you and say, okay, I want to fix my teeth, and why is that? And say, okay, I can't get a job because of my teeth are not straightened. And then you ask him, what do you do for a living? And he'll be like, I work as an IT consultant or IT developer, which means that they have no contact with people. He just deals with a screen. So how come your teeth will not get you a job? So that motivation, the true reason for motivation for treatment should be considered carefully. And that's to avoid any problem at the end of the treatment. Then the rate of tooth movement is something to consider. Now we know that the cellular activity for the adult patient is less compared to the adolescent. For that reason, the rate of tooth movement will be slower for adult patient. In fact, the delay will be slower in the beginning of the treatment, and there will be less reaction to the mechanical forces compared to the adolescent, which will result in a slower tooth movement in the beginning, but then the rate of the tooth movement between adolescent and adult will be the same. So quicker initial rate of tooth movement in the adolescent, just the initial tooth movement. Like once they start moving, there will be the same rate of tooth movement. That's similar to rolling a ball, a heavy ball. So when you start just about to move this ball, you just push it and it's not moving, it's very heavy. But then once they start rolling, start moving, the ease movement will be much easier. However, because the adult patient are more cooperative and they attend to the appointments more, they don't fracture brackets, that increase in the cooperation will compensate for the delay in the initial tooth movement. So that means the treatment time for adult and adolescent will be the same at the end. And that is because of the higher cooperation of the adult patient. So to summarize this one, adult patient rate of tooth movement in the beginning of the treatment is slower, but later on it will catch up and will be similar to the adolescent. So that initial delay is compensated by the fact that the patient are more cooperative. So where did we get this evidence from? As a paper done by Dyer et al. In 1991, in which he to get 30 adolescent girls only, so it's only female patient. And these were aged 12 to 12.5 years, and 26 women, which means adult patient, 27 years. Both of them were class 2 division 1 malocclusion. And what he concluded that adult treatment does not necessarily equate to the longer duration of the treatment. In fact, the average treatment time was similar in both groups, that they get 2.5 years. So according to this study, the rate of the tooth movement might be slower in the beginning of an adult patient. However, at the end of the treatment, the amount of the the duration of the treatment is similar. So that's according to Dyer et al. However, is this a good quality evidence? This is a retrospective study, and we know that retrospective study has a high risk of bias. There's no sample size calculation. The sample was only made from female, so there's no male in this sample size. It was, as we said, it was a retrospective study, no sample size calculation, only on female. So it's a low quality evidence about that, but this is the only paper that is comparing adult and adolescent rate of tooth movement. So for that reason, according to this paper, that the speed of the treatment or the time of the treatment is similar in both group, but the initial tooth movement is taking longer time in the adult group, but it will be compensated by the cooperation of the patient. Then the periodontal consideration. How is that we need to consider periodontium in adult patients? Well, patients who are adult, we might expect to have gingivitis, you might expect to have periodontitis. However, in the young patient who are adolescent, you might expect to see more gingivitis. While if the patient's oral hygiene was stayed poor for a while, you might see an adult patient with periodontitis instead of gingivitis. So the thing is that previous attachment loss does not mean that the patient can't go for orthodontic treatment. However, in order to start the treatment, we not make sure that there is no active periodontal disease. And we need to make sure that this condition is stabilized. And we need to make sure about that before we start orthodontic treatment. So what are the procedures that we should do first for a periodontally compromised or a patient that he had a periodontal disease previously and he wants to do an orthodontic treatment? Now in the UK, there's no clear guideline from the British Orthodontic Society or the Periodontal Society. However, there is a paper by Johar and Adil in 1999, it's called Orthodontics in Adult Patient with special reference to the periodontology compromised patient, periodontally compromised patient, and this is a review paper. So it's not a randomized clinical trial or something like that. It's only a review paper telling mostly it's not even a systematic review, the author's opinion. So it's low in the hierarchy of evidence. However, this is kind of the one regulating the UK at the moment. So the treatment goal for patients who have a previous active periodontal disease and he wants to go for orthodontic treatment. First, if he is a smoker, he should stop smoking because smoking increases the heat in the oral cavity, which results in increase in the breakdown of the periodontium. Now, if the bucket depth was between 4 and 6 before the beginning of orthodontic treatment, then it should improve on probing by at least 1 millimeter before orthodontic treatment can start. While if the pocket is more than 6 millimeter, then this pocket improvement should be at least 2 millimeter before any orthodontic treatment can be continued. Bleeding and black index should be, or score should be less than 15%. There should be cleanable teeth and prosthesis, and also no root caries. So whenever you have a patient as well, they recommended that you need to do a full periodontal evaluation. That means 6-point pocket depth for all the erupted teeth, and then you check as well the bleeding on probing, because bleeding and probing can tell you if this periodontal disease is active or not. However, the American Association of Orthodontics and the American Academy of Periodontology, they had made something they call a task force, and the job of this task force was to evaluate how orthodontists should deal with periodontally patient who had a previous periodontal disease. And they came up with the recommendation that any patient who had a previous periodontal disease and he's looking to start orthodontic treatment should have a series of x-ray in which he have an anterior periapical x-ray and posterior vertical bite wing x-ray to evaluate the level of bone support before you start the orthodontic treatment, and also to do probing of all the teeth. My personal recommendation is that for each patient or for all the patients who had a previous history of periodontal disease, you should take a periapical for the anterior and vertical bite wing for the posterior. Totally agree with that, because you need to check the level of the bone before any orthodontic treatment can start. Now, periodontal implication of orthodontic treatment in adult with reduced or normal periodontal tissue. So basically, okay, we know that we can't move the tooth if we have gingivitis. So from where did we get that evidence? Now, Boyd in 1989, he did a longitudinal study in which he looked at the periodontal status in 20 adults and 20 adolescents undergoing orthodontic treatment. Out of the 20 adults that we have, 10 of them, they had a generalized periodontitis and they received periodontal treatment, and including that periodontal surgery before orthodontic treatment, and then during orthodontic treatment they had a maintenance phase of 3 months interval during the orthodontic treatment. However, the other 10 adults did not receive any periodontal treatment. So what did he conclude? Tooth movement in the patient with reduced but healthy periodontium does not result in significant loss of the attachment. So basically, if you have a periodontal gum recession and you're going to move the teeth, if this periodontium is healthy, then any movement will not result in further loss of attachment. However, what he noticed that attachment loss is going to happen in a patient with severe periodontally compromised tooth that has a bucket of more than 6 millimeter and or advanced bifurcational or forcational involvement. So it means now if you have a periodontally compromised teeth or teeth that was affected by periodontitis and you want to provide treatment, you need to check the bucket depth. And if you see a patient with a bucket depth of more than 6 millimeter or a forcational involvement, then these teeth has a poor prognosis. They not have a good prognosis of these teeth. And as well as we mentioned, if we're going to start treatment with the bucket more than 6 millimeter, then we have to reduce it at least by 2 ml before any orthodontic treatment can start. So attachment loss also accelerated if the teeth were moved in the presence of an active disease. And that's here it's come the importance of having a stabilized periodontium before we start any orthodontic treatment. For this reason, it's not only important to check bleeding, probing, or any active periodontal disease before you start treatment, and also it is important during orthodontic treatment to make sure that the patient will not have eventually periodontitis and then more attachment loss during orthodontic movement. So to summarize the results from Boyd, he said, simply if you move the tissue in a healthy periodontium, you will not have attachment loss or like limited amount of attachment loss. However, if you do move the tooth with a bucket of more than 6 millimeter or forcational involvement, that will result in a compromisation of the tooth. And he said that attachment loss will be accelerated if the teeth is moved in the presence of an active disease. So that was by Boyd. However, we said that about moving the teeth in the periodontium. So now we know that we have to move the teeth in a healthy periodontium. So we can't move it in a disease or active disease periodontium. But is moving the teeth in a healthy periodontium will result in attachment loss? That's a question that was asked by Martin et al. In their systematic review published in the Journal of Clinical Periodontology, which basically is adult patient who's seeking orthodontic treatment and previous periodontitis will have an attachment loss. The answer was based on a small number of low quality studies. And by the way, in the lecture today, most of the studies are low quality because it's really hard to do a randomized clinical trial for periodontally compromised patient or patient who has a periodontitis. So they said that based on the small study of the low quality evidence in non-periodontitis and in a stable treated periodontitis patient, orthodontic tooth movement had no significant impact on the periodontal outcome. So basically the meaning of this study or the meaning of this systematic review, that if the patient has a periodontitis, previous periodontitis, attachment loss, but now everything is stable, moving the teeth within this periodontium will not result in attachment loss. Now, what about the orthodontic periodontic relationship, meaning how the teeth will react, how the periodontium will react for orthodontic movement? Now, there's a nice systematic review in the Journal of Oral Rehabilitation published in 2010 that summarized the orthodontic periodontic interrelationship. And that's a systematic review. So all the section that will be mentioned now about orthodontic and periodontal relationship is reference to this systematic review. So the first one is what's going to happen when we move the teeth in the infra-bony bucket or defect. So let's refresh your memory first. What do you mean by infra-bony defect? So if you can see here, we have a defect in the bone surrounding the teeth. And that one is classified into one wall defect, two wall defect, or three walls defect. So what is the meaning of that? So if you look here, this is the huge defect. So how many walls do we have available? Only one wall. So you can see this drawing, this is the tooth, here we have one wall. So this one we called one wall defect. When you go here, you can see this is one wall, this is two second wall, so that's mean two wall defects. While this one, everything is closed, so you have one wall, two wall, and third wall here. So we call it three wall defect. So when you say three wall defect, that's less severe than one wall defect or single wall defect. So what's going to happen if you move the bone tooth into a defect, infra-pony defect, whether one or two or three pony defect? The answer is movement could be successful and adequate control of this tooth movement is possible if the patient has absence of inflammation and there's no bacterial plaque. So again, movement without any inflammation can result in regeneration of the bone. So now what about orthodontic extrusion? We know when we extrude the teeth, we move them upward. So when you do this extrusion of the teeth, what's going to happen to the periodontium? So let's first do a quick revision for the anatomy of the tooth. So if you look at this photograph, this is what we call it, the enamel of the tooth. This one is called the gingival sulcus. This part from here to here is an attached mucosa, which means it has a keratinized tissue. This attached mucosa is divided into two parts. The first part is called the free gingival margin. It's called free because it's no attachment. As you can see here, it's free, it's mobile. It's called free gingival margin. Yeah. And while this one, the top of it, is called the gingival margin. Now, later on, we have, or next to it, we have the attached gingiva, which is this part here, which is attached, which is fixed to the bone. It's not moving. There's no groove inside it. And then we have the junction which between the attached mucosa and the alveolar mucosa. We call this junction the mucogingival junction. And the alveolar mucosa is non-keratinized mucosa. So basically, we know that the keratinized mucosa is more resistant into inflammation and to proclination as well. So whenever you examine a patient, you need to see how much attached or keratinized mucosa do we have? Do we have a big attached mucosa or minimal attached mucosa? And what is the thickness of this attached mucosa? Because all that will affect your tooth movement, as we're going to see later on. So that's a quick revision for the anatomy of the periodontium. So what's going to happen if you extrude the tooth? In a study that we mentioned that if you extrude a healthy mandibular incisors, the gingival margin, which is this one, will follow the extrusion by 80% of the extrusion. So basically, if you extrude the tooth by 5 millimeter, then the free gingival margin will follow by 80% of these 5 millimeter, which means 4 millimeter. So basically, if you have a short root or a short clinically crown, and you say, okay, I will give the patient a longer clinically crown, and then you decide to extrude this tooth, what's going to happen that the tooth is extruded, and for the most of the movement, the free gingival margin will move as well, the gingival margin. So basically, you're not going to get the teeth longer. The only way to get the teeth longer is to do crown lengthening. And the gingival, mucogingival junction, which is this one, will follow by about 50% of the extrusion. So if you extruded 5 millimeter, these will follow by 2.5 millimeter. But the important part that the relationship between the the cemento-enamel junction, which is this one, and the bone margin will remain similar or stable. What does that mean? So if you extract the incisor, if you extrude this incisor by 5 millimeter, the bone, the highest part, the crystal bone, the highest part of the bone will move upward as well 5 millimeter. So the distance between the cemento-enamel junction and the distance between the cemento-enamel junction and the bone, the crystal bone, will be similar. So this one, if you extrude the incisors by 5 millimeter, the bone will be extruded by 5 millimeter as well. So this is good. So if you have an extrusion bend, for example, you have a lateral incisor who is shorter than the central, then simply if you do the extrusion, the gingival margin will follow, which is good for ourselves because that will make finishing easier. But that's not good in the cases in which we don't want the bone to follow. For example, if you want to go, if there's a crown fracture, or if you have, you need to do a crown lengthening procedure. In these cases, you need to do what we call it circumferential supracrystal fibrotomy to cut all these ligaments and prevent the bone from following the tooth during extrusion. I'm going to show you an example for that to understand it. So if you have a clinically crown like this one, and as you can see here, we have a heavy restoration. The patient bited on this one, did not do crown, resulted in a fracture of the lingual wall, as you can see. Now when you take the lingual wall off, you can see that this fracture is huge, and this lingual wall is subgingival by 3 to 4 millimeter. So because it's subgingival, it means that you need to do with restoration. Your restoration would be subgingival. And as you know, the distance between this fracture and the bone should be at least 2 to 3 millimeter, which we call it the biological width. And if you avoid the biological width, we're going to have bone resorption. It will go further away to maintain this biological width, and the results will having a bucket in that area. So in these cases, what we can do, option number 1 is to do crown lengthening. So simply you open a flap here, you raise the flap, and you see where the fracture area, you reduce the bone by 2 to 3 millimeter, moving away from the fracture area, and then do a bically positioning flap so you not have a bucket, and you do suturing. Well, good, but then the problem with that technique that you have to remove a lot of bone from the neighboring teeth if you're gonna do this. So now that means that you will jeopardize the long-term survival of these neighboring teeth. So what shall we do? And instead of that, you can extract the tooth, and here the tooth is called non-restorable, or you can simply extrude the tooth. Now here, do we want the gingiva and the bone to follow? The answer is no. We want the fracture line to jump only. To do that, we can do a circumferential supracrystal fibrotomy, and that one should be done every 2 weeks. Now, if you don't do that, what's going to happen? And I personally don't do that. This patient attended the clinic, and we need to do the extrusion. His sister is a dentist. She doesn't want to do implant, and she asked for orthodontic treatment. So you can see here, we do the extrusion, and I don't like to do fibrotomy every 2 weeks, because in my opinion, and that's only a personal opinion, it's very painful to the patient. You need to give him anesthesia every time, and also it's not completely 100% protectable. It does not mean that you 100% you don't have to go for a crown lengthening, because sometimes you need to do the crown lengthening for other reasons, and also sometimes you do this fibrotomy and still the gingiva will follow. For that reason, I don't like to do it. So as you can see, when we do the extrusion, now you see the distance between the bracket head and the cusp tip, you can see that they will have like 3 to 4 millimeter, and now it's 0, because as we extrude the molars, I'm just trimming the occlusal surface. So then now you can see the level of the gingiva from here to here, which means when we did the extrusion, this is what we call it the gingival margin, it followed the clinically crown. So now so what we're going to do now, what we're going to do is to do crown lengthening, because now the fracture line is higher, so the surgeon does not have to go deep or like gingivally a lot to the point that he will compromise the neighboring teeth. And that's exactly what is done. You can compare here the level of the gingival margin in this tooth and this one, how extrusion is happened. So now the surgeon will come, or the periodontist will open up a flap. He will see the fracture line, which is now moved more apically, and then he will round the bone around this area, okay, and then close the flap. So the patient, as you can see, he moved the gingiva down. Now, if this was the original place of the gingiva, then he has to move it downward or like apically by 2-3 millimeter, which means that the root of the neighboring teeth will be exposed. So by here, we lifted we extruded the tooth. Now the gingiva followed, and the fracture line was higher. So now when we do the crown lengthening, the gingiva will go just normal place. So then patient is leaving for healing, and this is, as you can see, this is the fracture line. It's now supragingival, and then the patient will go for full clinical crown, as you can see here. And these are the margins after 1 year of treatment. Good. So now that's how we can benefit from extrusion. So simply the patient, we can save the tooth by simply extrusion. What else? You can see here we have a bony defect. So what's going to happen if I extrude this central incisor? Is this defect will be filled by bone? The answer, according to a very weak evidence that is done only on an animal study, is yes. That when you do extrusion, that extrusion with a bony defect will result in the bone to follow the extrusion. So that means that this bony defect will be smaller, will be shallower. And this is very important because in a grade 1, bone in the grade 1 bone defect, any bone defect of single wall is not eligible for a guided tissue regeneration. So we can do nothing for that because the failure rate is high. So the other option and the other advantage is to do an orthodontic extrusion for this tooth. And during that time, the periodontal, the bone will follow, so the defect of the bone will disappear. And here it comes something we call it force extraction. So what is the meaning of force extraction? So for example, if you have a tooth that is badly destructed like this one, and this resulted in a lot of bone loss in that area, either due to infection or due to periodontitis. So anyway, we have a poor, and at that time you will have a poor margin, and this is very important for aesthetic. So simply what you can do is to do extrusion of the tooth, and as you extrude the tooth more and more, it will move more apically and more occlusally, and it will take with it the gingiva and the bone, which means that it's building the bone as if you are doing bone grafting. But just remember that when you do this, you need to apply a labial crown torque, so that means that the root will be engaging more the bone, creating more bone during the extrusion. And then all of a sudden the tooth is out, you take it and then you place an implant. We call this forced extraction. But just remember that the rate of extrusion should not exceed the limit of 2 millimeters per month, and that you need to add labial torque to increase engagement to the cortical bone and more bone generation. However, once you do this, you need to you need to retain at least for 1 month. So opposite of extrusion is intrusion. So what's going to happen if I move this tooth down instead of extruding it? So well, again, in a healthy mandibular incisors, what's going to happen that the gingival margin will follow by about 79% of the whole distance, which is something very similar to the extrusion. And also the gingival margin, and the unicogingival junction will follow in a 62% of the cases, which again around that number that we got during extrusion. So what's going to happen if you intrude the tooth in a periodontally compromised tooth, like patient who has a previous periodontal treatment? So will intrusion will improve the attachment? We'll see. The evidence that we have is driven from paper from Ray et al. In 2004, in which he did a prospective clinical trial, all right, in which he got 28 consecutively patients treated in his clinic, and at least one of the incisors have a severe chronic periodontitis, and then it was extruded, and there's an infra-bony pocket or defect in the mesial side, and he collected these patients and he did treatment for them. And as you can see here, this is the defect before. This is the cemento enamel junction. This is the root. This picture from the paper. And here is the gingival margin. As you can see, intrusion resulted in improvement of the attachment. However, that he's mentioned 50% reduction in the recession after intrusion of the periodontally compromised teeth. And then the main issue is that you need to use a very light force of between 5 to 15 that will preserve the vitality of the tooth and will give a chance for a bone regeneration. Another example of intrusion, this patient in the clinic, and he is complaining about extrusion of the posterior teeth, who basically is not complaining about the extrusion, he just wanted to place an implant or restoration in the mandible. But because of the history of the extraction and long time without replacement, it resulted in over-eruption of the posterior teeth. So look here, we have a whole area of cementum available. So what's going to happen if we intrude this one? Now we said that with intrusion, this tissue in a healthy one should go upward as well, following the teeth, as we said in the study. But then what are we hoping for? That this doesn't happen. That when we intrude, the tooth feel as if it is sinking inside the bone. So what's happened after we do the intrusion? And we use that in this patient to reinforce anchorage. Intrusion is done, and here is the implant, and here you can see that the attachment has improved. It did not move all the way up. It is as if we do sinking of the tooth. So if you compare here, we have the forcation obvious in this picture before treatment, while here is just covered by the gingiva. So the intrusion resulted in improvement in the attachment, but the thing is that this intrusion will not result in keeping the bone where it is. It will move the bone up with it. However, the gingiva will follow, but not in a 1-to-1 ratio. So that means that we will create a bucket. because when you do the intrusion, if the bone goes up, that means that you will increase the sulcus depth, so you'll have more pocket. However, periodontists usually say this intrusion will result in something we call it adaptation, not regeneration of the pocket. So basically, the tooth, the soft tissue, will adhere to the teeth, and if you do probing, you can't get a pocket there. So, and that does not collect food, so that means that it kind of healed. So to summarize it, intrusion, if a healthy tooth, that means the gingiva will follow, while if it's a previous periodontal patient, intrusion will improve the attachment of the patient. However, it's not necessarily that the bone will follow. However, the gingiva might stay where it is according to Ray 2004. So what about molar uprightening? So what's going to happen when we upright the molars? So molar, when they tip mesially, that will become an easy area for food entrapment and inflammation and bone loss. So basically, we will have this defect, the osseous defect. And research has shown that if we do a brightening of this molar, this defect will disappear. However, as we mentioned earlier in Boyd paper, patient, if they have forcational involvement, that means that there is have a huge risk of aggravation of the periodontal disease just moving this tooth. So before you start uprightening the molar, you just make sure, as we said always, that there is no bleeding or probing. That will be done for all the teeth, and also that there is no forcational involvement. And again, now, what about moving teeth in an edentulous area? Is the teeth going to move easily in an edentulous area, or are we going to have bone loss? However, minimal loss of the alveolar bone is expected, but it's very minimal. As we are moving the teeth within an edentulous area, a little bit of bone loss will happen. However, the movement should be parallel and profound with low orthodontics force. That is the key point. Okay. However, when you do this movement and you need to do space closure or retraction in an adult patient, you need to consider that some of the extraction spaces are an old extraction spaces, which means that we will have nicking in that extraction spaces area. So what's happening? The bone, the cancellous bone will resorb, and the cortical bone will come, both of them, into contact. Now, when you have a cortical bone, it has two implications. The first one, cortical bone is harder, which means it's more difficult to move tooth within the cortical bone. As it's harder, it might cause more resorption to the root. So when you move the teeth in a cortical bone, that's very risky, because you might end up with root resorption, okay, and it might take a longer time. However, when you move the tooth, as you can see, this is a broad tooth, going to move it into an area of nicking like this one. We might have a risk of dehiscence of bone, in which this root will penetrate the bone as we are moving it into a smaller area. But usually, or narrower area, what we are hoping for, that the tooth, when it's moved, it will bring bone with it, making this ridge wider. So the movement of the tooth through cortical bone is retarded, and dehiscence might be developed, as we mentioned before, because when you're moving a wider tooth in a narrower area, might penetrate the bone. And in order to solve this problem, what simply we can do is something we call it ridge augmentation or ridge splitting procedure, in which you increase the width of the alveolar ridge by simply opening a flap, split this bone, open them up, place a artificial synthetic bone or just bone sample inside that area, and then close it. And by doing this, you will facilitate the tooth movement. Labial tooth movement and proclination of the lower incisors. We know one of the risk of the non-extraction treatment, you procline the lower incisor. And when you procline the lower incisor, you get a lot of space. So it's kind of very efficient in providing space in the cases that you don't want to treat with an extraction. But the thing is that there is a huge side effect for this proclination that might result in gingival recession in that area of the proclination. Now, the highest predisposing factor for this proclination is not how much proclination you do, but it is what is the thickness of the soft tissue and bone before we start this proclination procedure. For that reason, when you have a patient in the clinic, you need to make sure to examine the thickness of the soft tissue. So what is the evidence saying about this? Now this is a systematic review in which it looked into the gingival recession upon labial movement, but not for adult. It's adolescent and adult patient. And what did they found? They found that there's no association between the appliance-induced labial movement and the mandibular incisor recession. However, they mentioned that there is cases in which they have recession, and they counted the risk factor to be reduced thickness of the free gingival margin, as we said, narrow mandibular symphysis, inadequate plaque control, and aggressive tooth brushing, that they're having a higher risk of gum recession when we procline the incisor. So when you have a patient and you need to procline the lower incisor, you need to examine the thickness of the attached mucosa, and you need to make sure that the patient has a healthy gingiva and no aggressive tooth brushing. However, what we believe, and the periodontists believe, that usually proclination of the lower incisor will not lead in attachment loss. But what happens is proclination and excessive proclination will make the bone thinner and will make the soft tissue thinner. So they will become less resistant to any inflammation and gingivitis and bone resorption and periodontitis as a result. So for that reason, when you procline, the bone becomes thinner, the soft tissue becomes thinner, and as a result, any orthodontic treatment, any inflammation will result in more recession for this patient. So oral hygiene reinforcement is very important during that stage. Then we have an anchorage consideration. So what about anchorage consideration with adult patients? So if you look at this photograph here, we know that the center of resistance of the tooth is equal to the middle of the root of the part of the root embedded inside the bone, which means that the level of the bone affects the location of the center of resistance. If we lose bone, the center of resistance will move more apically. Not everything will move, only the center of resistance will move apically. So, if the center of resistance moves apically, then this distance from the area we apply force into the center of resistance will increase, which means that we have more moment. To counteract this moment, we need to have a counter moment, which is use a couple force to counter that one. So because the distance from here to here is increased, so then the moment has increased, and then the force that is generated is increased. So the force that he generated here will definitely be bigger than the force generated here. So more anchorage demand. On the other hand, this tooth has a better bone support, while this one has a little bone support. Which one is going to provide better anchorage is the one with more bone. We call this anchorage value. So the tooth with periodontal recession will have a less anchorage value compared to the patient without bone loss. So that means that when you have patient with bone loss, first the center of resistance moves apically, which means that we're going to get more tipping, and you need more force to control this tipping, more couple force to control this tipping. And then these teeth that you're going to move and you're going to rely on for anchorage, they are not of a good anchorage value because of the bone loss. So you have to end up reinforcing anchorage. That's the one I mentioned. And usually remember that if you decide to reinforce anchorage, adult patient doesn't like anything that affect their appearance, so headgear will not be the best option. Usually we go for nans or tads. What about the non-growing? So if you treat a patient who is class 2 and you know that he's still growing, even though your first option will be using a growth modification. So you use the growth modification, and that helps you a lot to correct the class 2, the overjet, and to improve patient profile in certain cases. While if an adult patient attends your clinic with a class 2, there is no other option or no other things to help you to correct this class 2 because the patient has finished growth. Now, if the patient is after the age of 14 but he's still growing, and we're not going to use functional, we're going to use only fixed appliance, the growth of this class 2 patient is working with us. So you can see the patient, and then a month or two later, you can see that the canine molar relationship has improved by a half a unit, for example, and that is purely due to growth, which is an advantage that we're going to lose in an adult patient. So in an AB direction, we lose the growth. So now we need to camouflage it, and we can't correct the patient profile if he has a complaint unless you go for surgery. We also have a problem in the transverse relationship because simply the suture now has closed, and if we plan to do any expansion, any skeletal expansion, RME is not good for these patients because the suture has closed. The only way, if we want to do expansion for this patient, or the only two ways, is to do SARBI, for example, which she go for surgery, we call it surgical assisted rapid maxillary expansion, or to use MARBI, which is mini screw assisted palatine expansion. So basically use the screws to open up the suture, which is a little bit more expensive and involve a lot of mini implant insertion. However, just remember, in the transverse relationship, we can't do skeletal expansion unless we're using TAD or split the suture. That's as a result that we don't have growth. And also in the vertical relationship, so you can't extrude posterior teeth. So if you have a patient with deep overbite and he's still young, so simply what we can do is to use a flat anterior bite plane. This flat anterior bite plane will result in a separation between the posterior teeth. So now the posterior teeth has a space to over-erupt. This over-eruption will reduce the overbite. We call this relative incisor intrusion. But remember, when you extrude the molars, you are increasing the posterior facial height, this area. But because the patient is still a grower, so that will be compensated by the growth of the patient. But the case is not the same when you are doing this with an adult patient, because if you simply extrude the molars, the patient is still not growing. The muscles of mastication that are here will be stretched, and they will not be happy. So they will exert a higher force that will result in intrusion again and relapse of the treatment. So the other option to relieve or to correct the deep overbite or to level the curve with speed in an adult patient is simply to do proclination or intrusion of the incisors, but not extrusion of the molars. Space closure. Now, we mentioned that when we do space closure, we need to watch for the nicking of the alveolar mucosa. So in the beginning of the tooth movement, it will be slow because of the less resilient of the bone and flexibility, but then it will catch up and it will be the same as adolescent patient. However, sometimes if you have a bone nicking like this one, that will delay the space closure because you need the light force to move the tooth inside this one. Tooth movement will be in a cortical bone, so we need to observe carefully that this will not result in a dehiscence. Don't forget that we can do ridge augmentation to split the suture and insane board grafting. Restorative consideration. If you need to do bundle for adult patients, usually this patient has already restoration. So when you have restoration, they have amalgam restoration, they might have gold restoration, they have a ceramic restoration. So you need to be familiar with the techniques that are used to bond to these surfaces, and that topic was discussed in the orthodontic material lecture last year, and we will repeat the lecture this year covering how to bond to the different surfaces. However, whenever you treat an adult patient with a porcelain restoration, you need to always warn the patient about the possibility of fracture, of chippment of porcelain during debond, because that's always a risk factor. Aesthetic consideration. Usually patients who are seeking orthodontic treatment as an adult, they like the aesthetic option because they don't want to show the braces, especially if they work on teaching, lecturing, or like interacting with people. They will ask more for aesthetic appliances, and luckily we have many options: lingual orthodontic, ceramic orthodontic, which is a buccal one but only ceramics. You can use aesthetic arch wire, which is on the regular braces, but instead of using metal one, we're using coated wires, which is white in color, and the line is the last one that we can use. So now we talked about the periodontal consideration, the type of the appliance that we can use. From aesthetic point of view, definitely a liner is good because the patient can show it and can see it. And we saw that periodontium is very important and very big role to play in adult orthodontics. So what about the appliances that are aesthetically acceptable and the periodontium? So is using a clear aligner treatment will promote more healthier or healthy periodontium? That's a paper published in the European Journal of Orthodontics in 2015. They did a systematic review in which they looked at the periodontal health during clear aligner treatment, and they found that there is a significant improvement of the periodontal health index in the clear aligner treatment group as compared to the fixed appliance tube. Okay, so no periodontal adverse effect was noticed in the clear aligner treatment. However, the level of the evidence is weak, and this result should be interpreted with caution. A more recent meta-analysis published in the 2018, they found that systematic review, that the idea of this systematic review, was to compare the periodontal health in patient going for clear aligner and fixed appliance treatment, and he found that clear aligner were better for periodontal health than fixed appliance. So simply, if you have an adult patient, you might think to go to clear aligner treatment to aesthetics number 1 and periodontium number 2, as it has less plaque accumulation and so on. Stability consideration. Now, if we have an adult patient, an adolescent patient, and the adult patient has no history of periodontitis and attachment loss, so he will be exactly similar to the adolescent patient. There's no difference. But the difference happens if the teeth are periodontally involved. So what's going to happen if the teeth are periodontally involved? Then you lose the attachment. So losing the attachment makes their movement easier. So if you have a spacing and before that you had a periodontally compromised teeth, when you remove the brackets, it will be easier for them to move. So here in these cases we need to use a bonded retainer, and we have the advantage of the bonded retainer here that other than bonded retainer, it will act to splint the teeth together. However, also make sure that if you have an extraction space and you decided to do an orthodontic treatment, closing these spaces are difficult because you are removing teeth in the cortical bone, but then again maintaining these spaces closed as well is difficult because the teeth might move and reopen up the space. So if you have a patient who is an adult patient, you need to consider using bonded retainer and vacuum formed retainer for these patients. Now, there's a term that came up recently, it's called short-term orthodontics. So what does that mean? Adult patients usually come with a specific complaint, for example, a crowded incisor, and he will want this one to be fixed. Now, he doesn't care if the canine is a half unit class 2. He doesn't care if the molar is a quarter unit class 3. He just wants the incisors to be straighter. And here it came up with something we call it short-term orthodontics. So basically this option addresses the patient concern only. So does not correct anything else. And that because it's called short-term. It's just short one. However, when you do this one, you just need to make sure that you give the patient the correct and the full detailed treatment options, and he has to pick and choose this one, not to force him to go through this one, because some others, they want to fix all the problems that they have in their teeth. So you can do a short-term orthodontics. You need to make sure that the patient are aware of the other options and they are happy to proceed with this option, and also that there's no harm to the patient. There is no side effect caused by short-term orthodontics. However, just to keep in mind, if you decided to do a short-term orthodontic treatment, which basically in most of the cases will be relieving of the anterior crowding, you're most probably going to provide space by proclination of the anterior teeth, which means that the teeth will be more protrusive, or it will result in an increased overjet. So this is something to consider when you do a short-term orthodontic treatment. This is an example that is used in the UK. It's called the Inman aligner. So basically it comes with nickel titanium spring. It does expansion, so to level and align the teeth. You can see here bad in the posterior and bad posterior to the incisor anterior. And what happens is that when you expand with this appliance, the teeth will spread because it's guided by this acrylic here. The other thing is called 6 month smile. So basically, as the name implicated, that you get your smile in 6 months, and this one basically they do alignment of the front teeth, alignment for the 6 anterior teeth. Again, you need to do a good patient selection, because patients might only want this as a problem and doesn't care about the rest of the problems. However, you need to make sure that the patient is aware with all the treatment options. Thank you very much.